Welcome to NCOPE's webinar regarding the 2025 residency standards, an overview for future and current residency directors, administrators, as well as staff members engaged with orthotic and prosthetic residency. My name is Chris Robinson. I am NCOPE's Clinical Resource Director, and it's an honor and pleasure to have you join us today. I'm excited to share with you NCOPE's goals and responsibilities, the importance of residency standards and how the new standards are structured. We're going to discuss qualifications for residency mentors as well as directors. We're going to review locations that can serve as residency sites, as well as pathways to completing orthotic and prosthetic residency. We're going to discuss the new concept of minimum activity volumes and also review updated competencies. We're going to discuss competency frameworks across health profession education in general. And finally, cover recruiting and advertising requirements for residency sites under the new residency standards. I always like to put the bottom line on top, if you will. The 2025 residency standards are truly an evolution in how O&P residency programs train orthotists and prosthetists. And although there's a considerable number of updates, O&P residency is going to continue to serve as the second half of the orthotist-prosthetist education, and the residency sites of today will likely continue to be able to contribute to residency education well into the future. So if you remember only one thing from this talk, it's the fact that the new residency standards do not change the core purpose of residency education, and the residency standards are crafted in a way that we hope to enable residency sites of today to continue to shape the future of our profession well into tomorrow. As a not-for-profit organization, NCOPE is driven by its mission, vision, and goals. Our mission is to create, uphold, and advance rigorous educational standards to develop highly skilled orthotic and prosthetic professionals. Through collaboration, data-driven practices, and robust accreditation process, we aim to improve patient outcomes and elevate the profession. And we have an aspirational vision of promoting excellence in education and training to inspire and empower future O&P professionals. We achieve this mission via our goals: standards in O&P education, accreditation and quality assurance, community collaboration and communication, as well as internal organization engagement and alignment. Now, O&P residency offers key real-world experiences with the goal of developing an independent, competent, entry-level clinician. And at the end of the day, the word independent is what I really want to focus on. That's the difference between school and residency. Residency achieves independent, autonomous practice. Furthermore, it can be argued that the O&P residency is the most relevant component in the practitioner's education, as it's intended to be a structured, immersive, real-world experience. I want to clarify, though, that how we define competency within the residency standards has been updated. Furthermore, the idea of structure in residency, structure is a much greater role. It is a cornerstone, if you will, of the 2025 residency standards. Now, if we think about our residency stakeholders, there's four major groups. The patient, they have to be first and foremost. And providing appropriate patient care is the ultimate goal of residency. The resident is an extremely close second, part learner, part employee, multitasker, and truly the future of the O&P profession. There's a faculty, and many of you might be thinking, that sounds like a professor, but I'm actually talking about many of the attendees right now. Residency directors and mentors, you are the faculty. And you, along with your colleagues in the patient care team, shape the residency learning experience. And NCOPE is last and least, because as an accreditor, NCOPE ultimately defines standards to ensure graduates of schools and residency are competent. And it's not done by any one of the four people on that screen there. The actual standards are defined by a board of directors, public comment, and lots of other processes. And actually, a lot of you contributed to the creation of the new standards. So I'd like to extend a blanket thank you to a lot of the individuals kind enough to join us live. On the screen here, I want to talk a little bit about the transition to new residency standards, as well as certification exam timelines. The chart on the screen is something that you likely have seen at one point or another. But I want to clarify that the residency standards are evolving to align with the updated certification process and trajectory of the profession. Key dates for NCOPE, those are in blue, while the key dates for ABC, those are within orange. Let's focus on NCOPE though. July 1st, that's when the NCOPE residency standards are implemented. And as you're about to learn, it's actually not going to be a broad sweeping change. So if you're thinking, Chris, is there a lot of change happening in the next 11 days? The answer is no. Also, November 30th of 2026, that's the last day that a resident could potentially start a single discipline orthotic or single discipline prosthetic residency, because there's a lot of individuals that graduated in 2024 or 2025 for that matter, who ultimately wish to pursue the more traditional accreditation pathways and certification pathways. So they're pursuing residency where they would do 12 months of orthotic training followed by 12 months of prosthetic training. But that's going to end. And we know for a fact that on November 30th, 2027, that is the last day that we could possibly operate and implement single discipline residencies under the old standards. So there's a period of time that's built in to allow us to let persons who did graduate last year and this year the opportunity to finish things out in the manner that many of us were trained. You'll notice that ABC is transitioning to a combined CPM and simulation exams. They've already done this for the written exam, but doing this for the simulation and CPM exams, that cuts the number of tests needed to become a CPO from 6 when I took them some time ago to just 3. So the fundamental question that I'm asked on a daily basis is, what will happen to sites accredited under the current residency standards on or after July 1st, 2025? And although I mentioned on July 1st, 2025, we have the term implementation date, there's not going to be sweeping changes for sites that actually were accredited prior to that. As a matter of fact, sites don't need to come underneath and operate in compliance with those new standards until they either renew the accreditation in the case of my existing sites, or a clinic that's not held NCOPE residency accreditation recently seeks initial accreditation. So on this webinar right now, I have a couple of sites that actually aren't set to renew until January 2027. That means you're going to run just the way you always have run up until that point. Now let's talk in the terms of residents. Residents that enroll at a residency site operating under the current residency standards, meaning the standards in place prior to 2025, they're going to keep their residency moving along as they always had planned. There's not going to be any significant changes for those individuals. Now, residents that enroll in a site operating under the 2025 residency standards, so these are sites that actually get accredited on July 1st or later. Those individuals actually are going to be completing their residency in full compliance with those new standards. But as I've already alluded on the last slide, we have a transition plan for folks that said, you know what, I'm going to do the old-fashioned 12-month single discipline residency process. So don't worry, we're not forgetting about the hundreds of individuals who graduated last year and this year. So what do residency standards represent, and how are the 2025 residency standards structured? I just want to be clear that the word standard means that it's not a suggestion, but truly the minimum bar that must be cleared by the residency program stakeholders, and also demonstrated via the resources at the O&P residency site. Furthermore, the 2025 residency standards are broken into 5 sections with 4 appendices. One thing I want to be clear about, though, is the current standards, as well as the old standards, have 5 sections, but the contents of those sections, it's quite a bit different. The new standards are actually much more structured. And furthermore, appendices enable us to make more frequent updates as the profession evolves. We needed to evolve these residency standards to reflect modern clinical practice. So where can residency training ultimately occur? An ABC or BOC accredited O&P patient care facility. One thing to keep in mind, though, is BOC is currently undergoing a process and is suspended from participation in CMS programs in the states of California, Florida, New York, and Texas. Furthermore, residency training can occur at OMP patient care facilities that partner with integrated residency programs. These are programs where an academic degree is awarded after completion of both academic training as well as the clinical residency training piece. And we have a term for those clinics. They're called academic partner clinics. International clinics are welcome to actually seek accreditation as well. The program doesn't need to be housed exclusively within the United States. What they do need to do, however, is to ultimately meet qualifications to provide comprehensive OMP care based upon the local governing authorities and demonstrate equivalence to ABC facility accreditation standards for comprehensive OMP care. And last but not least, OMP facilities providing comprehensive care that hold OMP facility licensure are eligible to apply as well. Just keep in mind, depending on how the organization is credentialed, whether it's international, state licensure, BOC, or other needs, additional documentation may be needed to demonstrate resources and personnel meet the standards. So as always, NCOPE does reserve the right to require not only additional documentation, but also to perform a site visit to ensure those resources are in place to host a residency program. So what comprises a residency site? The primary clinical facility and any additional clinics recognized during NCOPE residency accreditation process is defined as the residency site itself. So a site is not just one building. It can be multiple clinics. And under the previous OMP standards, we used a term called affiliates, but it was a blanket term and didn't do a particularly good job of defining the various types of organizations that partner. So now we have new terms. There's local satellite clinics, and a satellite clinic is owned and operated by the same organization as the primary clinical facility within a 50-mile radius. And some of you might be thinking, Chris, the old standard said 75. What's the deal? We actually are comfortable operating within this 75-mile radius if the primary facility and that satellite/partner clinic are in a designated rural area. So if you happen to be in an area that is more rural, it's not uncommon to have 60 miles between your clinics. NCOPE is going to be supportive of having local satellite clinics within a 75-mile radius, so long as you can demonstrate you are within a rural area. Now, besides satellites, there's a term partner clinics. And partners are organizations that are not owned or operated by the same organization as the primary clinical facility. A good example of this is the U.S. Department of Veterans Affairs has 21 accredited residency sites, and they don't provide very good access to pediatric patients. So all of them have agreements in place with facilities that enable access to pediatric patient populations. Those clinics that provide pediatric assets that aren't owned by the U.S. Department of Defense, those are partner clinics. And another thing that's really exciting is this idea of remote satellites as well as remote partners. And we were approached by a clinical organization that said, Chris, we have residency sites throughout the United States. We're talking multiple time zones. And we want to create a program where residents have the chance to rotate through, let's say, our facility in Philadelphia, PA. And then we're going to have them go down to St. Louis or up to Detroit, Michigan. We're supportive of that, but this needs to be done using what's known as a remote satellite or partner agreement. The term satellite applies to clinics owned and operated by the same organization, while the term partner refers specifically to clinics that are owned and operated outside the scope of the organization. These remote rotations must not exceed 2 weeks for every 52-week period unless the resident agrees to an extended placement prior to the residency position. So the clinical partner that we spoke about earlier, they actually said, you know what, we're going to advertise and tell the residents right away before they even sign up. We want you to rotate to 4 different unique facilities that are hundreds and hundreds of miles apart because we want to give you a really unique clinical training opportunity. Let's talk about residency program types as well as sites. And under the previous standards, there was this idea that residency sites were able to be held at facilities that could offer training to one discipline or both disciplines. And actually, This still can occur under the 2025 residency standards. If you're at a children's hospital that only offers pediatric orthotic care, you could still get accredited as an NCOPE residency site. But under the previous standards, that children's hospital, they could do an orthotic focused residency. And at the end of 12 months of focused orthotic training, that resident would then receive a certificate of completion. Under the new standards, NCOPE can only award certificates of completion when the resident is trained in both orthotic as well as prosthetic clinical practice. So how's it going to work for the children's hospital? It only does orthotics, for example. Let's imagine they go to the children's hospital for a 12-month period of time. That's a time that they feel they could provide the resident with adequate exposures. They complete all of their minimum activity volumes, requirements, and competencies, and then they go to a facility that focuses on prosthetic care or maybe does ONP care. So for the resident that's thinking, after doing that children's hospital I always wanted to go to, maybe I'll go to a Center for Prosthetic Excellence. I know a clinic down in Oklahoma City. That would be great. No problem. And after that resident finishes their training in both ONP at 2 different facilities even, well, they get their certificate of completion. The biggest change with these updated standards is the fact that the new NCOPE residency standards simply don't have a mechanism in place to recognize completion unless training in both disciplines occur. So sites that can only do prosthetic training, they can continue to train residents, but they're going to have to get their orthotic training elsewhere. So who can be the director or the residency mentor? First of all, supervision of the residents must only occur for the disciplines in which the director or mentor supervising them is certified or licensed in. And the director and mentor requirements, they're virtually identical. The only major difference is how much post-certification experience that person must have. The director, they need only 4 years of post-certification or licensure experience, while the mentor, they need only 2 years of post-certification or licensure experience. And for those of you thinking, wait a sec, I know the previous standards, and it said 3 years for mentors and 5 years for directors. Why would you do this? Interestingly enough, if we looked at the years of experience relative to the actual residence review and rating of those mentors, they were inversely proportionate. That's right. Mentors that actually had less experience did a better job based on the residents' perceptions, while the mentors with 35 years experience, they actually didn't score quite as high. Now, does that mean if you have 35 years of experience, you're a bad mentor? By no means. There's some amazing mentors with decades and decades of experience. But the key here is we realize that individuals that actually completed a master's degree in a modern residency program, they can relate to the resident a little bit better. And that's why we're allowing individuals with as few as 2 years of post-certification licensure experience to serve. Also consistent with the previous standards, there's the requirements of formalized OMP education. And you notice that a baccalaureate, post-baccalaureate certificate, or master's degree is required for both the directors as well as the mentors. Furthermore, online development courses are being updated as we speak, but we're going to require that all mentors or directors complete online training within 3 years of seeking accreditation. Another thing to keep in mind is only a single person can hold that title of director. And this is for accountability. We need one person at the top of the totem pole, if you will. That person is responsible for everything, and they can dedicate and allocate associate directors. But those associate directors work underneath. They have the permission and privilege of doing anything the director can do. But think of it like a totem pole. There only could be one owl at the very top of your totem pole. Another change for the better. The director or associate director must be active in the feedback process. And if you're a smaller clinic, odds are you're the director and the mentor. You're also the chief human resource officer and maybe even your own technician, and that's okay. But there's also bigger residency sites where the director, they might not ever actually set foot in the primary clinic where the resident's at. But that director needs to be aware of how things are going. They need to be active and involved to be aware. Is the resident getting access to appropriate resources? Are they getting timely and meaningful feedback? So the director must be present during the feedback process every quarter, even if they weren't the main supervisor. Now, the director or associate director are acceptable in this, and it doesn't require that they be physically present. So if you're thinking, Chris, I can't afford that kind of airfare, you don't have to. You can actually use the free version of Zoom and it will work just fine. So when is a residency considered complete? At the end of the day, there's an awful lot of things needed for a residency to be truly considered complete. The resident must register, they must be active in patient care, they must log all their cases within 14 days of actually seeing the patients themselves. But ultimately, if you were to read through every one of these columns line for line, they're identical. The way that residents log their case is an NCOPE tracker. It's the same. The need to adhere to the professional code of responsibility defined by ABC, it's still there too. Demonstrating required competencies, also still there. Furthermore, the final eval of the resident must be completed by the director, just like the previous draft. These are identical. So let's think of it in the context of what is a little bit different for the mentors, if you will. Under the previous OMP standards, the residency mentor submitted 12 competency forms in addition to quarterly evals of the resident. That's right, no less than 18 forms had to be filled out to be trained in ONP, assuming a 6-quarter residency, 12 competency forms, and actually would be 19 forms if you include technical competency as well. The new standards, we're down to 6 forms. That's right, fewer forms. We've integrated the competency assessment components into the quarterly evals. And we do competency assessment at minimum quarters 2, 4, and 6. Although they can do competency assessment on a more frequent basis as well. Furthermore, we need feedback from those mentors about how that individual performed as a resident based on the training they received at their school. So all mentors are required to fill out the evaluation of the CAHEP education form. The old standards, it wasn't a requirement, but a lot of mentors filled it out anyway, and we appreciate it. But the new standards, we need to get feedback to our master's program. So what's different for our residents? Well, under the previous standards, resident self-evaluations, they weren't a requirement, but we recognize self-evaluation enables reflection and helps calibrate the resident's personal understanding of their progress with the mentor. So under the new standards, that resident performs self-evaluations every single quarter, as well as during the first month of residency. We talk about the evaluation of the CAHEP education. Under the previous standards, the resident didn't have to worry about filling out that form, but many residents did. And it gives wonderful feedback to the schools about how well school prepared them for residency. That form now, it's very much a requirement. So what's different with balancing ONP patient care? Under the previous standards, when the resident completes all requirements for an ONP residency, they had to do 50% of their time on orthotic care and 50% of their time in prosthetic care, assuming they were pursuing a combined OMB residency. Under the 2025 standards, we're less concerned about the percentage of time a resident spends engaged in one discipline versus another, but we're very much concerned with, are they hitting minimum activity volumes? So one question I'm often asked, and actually there's a lot of sites on this call right now. The site director often will say, Chris, we have a long established history of training residents focused on orthotics first and prosthetics second. Can we still do that? And the answer is absolutely yes. If you're at a site capable of training an individual in both O and P, for example, University of California, San Francisco has offered orthotic training and prosthetic training for years. They could structure their residency program to focus on one discipline at a time, even under the new standards. Just keep in mind, NCOPE can still only give a certificate of completion after they're trained in both disciplines. Furthermore, we talked about that children's hospital that can only offer training in orthotics. Can they still be NCOPE accredited under the 2025 standards? You bet. And at the end of the day, while we can't give a certificate of completion after training in just one discipline with the new standards, if the resident were to complete their training in orthotics at the children's hospital and then go to a facility for their prosthetic focus, they would get a certificate of completion after going to both of those unique sites, and they would complete what's called a 2-site residency program. And they get one certificate of completion with both sites' names clearly listed. So let's work through this. I mentioned University of California, San Francisco earlier, and they're capable of training residents in both orthotic and prosthetic practice. And under the previous O&P residency standards, that resident would register for an orthotic residency. They do a single discipline orthotic residency of no less than 12 months. Then they get a certificate of completion. They'd be an exam candidate for the ABC orthotic sim and orthotic CPM. And then they could register for their prosthetic residency and do it all over again. 12 months of training in the prosthetic discipline, another certificate of completion, and finally eligibility for those prosthetic boards once the certificate's awarded. Under the 2025 residency standards, the resident only has to register once. So they register to enter a combined residency, but they do nothing but orthotic management. And this is for a period of no less than 9 months. That's right. But the resident focuses on just orthotic care for 9 to 12 months, prosthetic care for 9 to 12 months. And they get a single certificate of completion for combined O&P residency. It has the single clinic's name because they completed this all at one facility, UCSF in my example. But then they're eligible for all ABC exams once that certificate of completion is awarded for both orthotic and prosthetic care. So this is probably the biggest epiphany a lot of directors have had. So combined O&P residency doesn't require residents provide O&P care week over week, 50% O and 50% P. No, that's over under the 2025 standards. Now, if your site's accredited under the old standards, time still applies. But we're going to have a mechanism for sites to get accredited under the new standards so you can focus on MAVs and take advantage of all this flexibility. Heck, let's give you some more examples. Let's go ahead and talk things through with the two-site residency training pathway. So under the current O&P standards, let's imagine we have Site 1, BraceWorks Clinic. They only do orthotic care. The resident enters their residency at BraceWorks. They do 12 months of training, meet all the requirements. They get a certificate of completion. They're eligible for their ABC, SIM, and CPM. And then they register for a prosthetic residency somewhere else. Let's say they go to Prosthetic Ninjas. And at Prosthetic Ninjas, they get another 12 months of training. They get a certificate of completion for their prosthetic residency, and now they're eligible for the prosthetic SIM and prosthetic CPM exams. But under the new standards, the resident would still register twice. They'd register once before going to BraceWorks, and they do focused orthotic training. And once they finish up their time at BraceWorks and all their requirements, they wouldn't get anything but a fist bump from the person who trained them in orthotic care and a good luck. And that resident would have to register at the prosthetic focus clinic next. And they could do it either at a clinic that does exclusively prosthetic care or a facility like UCSF that can actually train people in both. But the catch is that certificate of completion, that check mark, it only happens once. But once you get a certificate of completion for training in both O and P, you're now eligible for all your ABC exams. The big thing with the two-site pathway I want to be totally clear about is BraceWorks and Prosthetic Ninjas, my two example clinics here. They don't need to be affiliated in any way. The directors could have never even met once in their lives. This is totally independent. And for the residents that actually go, Chris, I have a vision. I want to go to Centers for Excellence in O&P training. We can work with you. So one site versus two site requirements. A one site residency can occur at any facility that's able to offer training in both orthotic as well as prosthetic clinical practice. And at those clinics, the resident registers only once, and the resident gets training in both disciplines at the site. They actually have no defined minimum percentage of time spent on O versus P training. They must meet their defined minimum activity volumes, however, which we'll talk about in a moment. And the program could be structured with a combination of rotations, including combined O&P, where they might see orthotic and prosthetic patients day to day, or they could have focused stints of training in just prosthetic care or just orthotic care. That's okay as well. The two-site residency requires the resident to register twice because they're going to have to go to two different accredited sites. And they get training at those two sites focusing on only O or only P at each site. This is a little bit different, but again, this is to make sure that individuals are getting focused on their enrolled discipline. If a resident does pursue a two-site pathway, they must focus 100% of their time on their enrolled discipline at the initial residency site. So if they start at BraceWorks Clinic, as I showed on the previous slide, 2 weeks after they graduate, 100% of their time is dedicated to orthotic cases. Even if Braceworks has a prosthetic case once in a while, they need to focus on orthotics. But then when they finish their time and requirements in orthotic care and they say, I'm going to go to my second site, Prosthetic Ninjas, here I come. They can go to Prosthetic Ninjas, but at the second site, that resident must still focus at least 80% of their time on the enrolled discipline. So there was a term we used to have called title extension under the old standards. Title extension no longer exists because there is no way to get certified in the middle of your residencies. With single discipline exams being phased out, you won't be able to even register for them after December 31st, 2027. Title extension has to go away as well. And when we talk to residents, actually recent residents and current residents are one of our main focuses when we wrote the new standards. The biggest complaint residents had, it was residents that said, I did an orthotic residency followed by a prosthetic residency. And during my prosthetic residency, I was trained poorly as a prosthetist. I didn't get enough time. That is why the idea of title extension and the requirements for increased time at a two-site model is required. We need to make sure they get the reps they need. Will sites be allowed to offer a single discipline orthotic or prosthetic residency during this transition phase? We graduate about 300 people a year from our master's programs. What's going to happen to the folks that signed up for an orthotic residency that are finishing up right around now? Are they going to be okay? The answer is absolutely. Residents will be allowed to register for a single discipline residency as defined under the previous standards at a site, so long as that site held accreditation with NCOPE before July 1st. The resident's start date is no later than November 30th, 2026, and they finish all their training no later than November 30th, 2027. So that means if you start your prosthetic residency on November 30th, 2026, you can't get sick, you can't take a leave of absence. These single discipline residents will be held accountable to the previous single discipline standards because single discipline residency, that term doesn't even exist in the new standards. But we'll get these folks certificates of completion in just orthotic or just prosthetic management because that was allowable underneath the old standards. The one thing I want to be clear about, though, is if you are at a residency site that's not accredited right now, and I'm doing this talk on June 20th, 2025, you're going to need to get accredited under the new standards. And when you get accredited under the new standards, assuming you've never been accredited under the old ones, you won't be able to host single discipline residents under the old standards. So any place that comes on as a quote unquote new site needs to operate exclusively under the new 2025 standards. Residency sites must define rotations and structure. You need to identify within your program, ultimately, how are residents going to be spending their time? And also a program length. Some residency sites go, we're going to do 18 months for you, 24 months for you. You can't really mix it up. Define it and be proactive on the front end. So if you want to do a 24-month combined O&P residency, that's great. You're going to identify it in the application. And when a resident registers, they're going to need to go for 24 months. They won't be able to cut it short. It'd be kind of like getting your master's degree and saying, I feel like I know enough. Could I take the last semester off and call it good? No, you don't get your degree. And unfortunately, we can't give you a certificate of residency completion either. So sites need to define the length and also rotations. Now, we're not looking for anything super in-depth. Let's imagine that we have a clinic with multiple offices. And we have one practitioner, Carl, who does orthotics, adult, Q1. Q2, you're going to rotate over to Carla and do peds orthotics. Q3, you'll do adult and geriatric lower limb prosthetic care with Carlito. And then Q4, Carlton's going to show you upper limb prosthetic care. Q5, Karen's going to focus on peds prosthetic care. And Q6, your final quarter, multiple limb loss and high activity prosthetics and orthotic care with Carney. You can base it on the treating clinician. You can base it on the populations you see. Heck, you can even just base it on days of the week if you want to work office to office. In Chicagoland, the local Hanger Clinic, they have the Oak Park and Westchester clinics. They're very busy offices, but see very different populations. During Q1, the resident spends Monday, Wednesday, Friday in Oak Park, Tuesday, Thursday in Westchester. Second quarter, you're going to spend Mondays at the Children's Hospital, Tuesday through Friday at Rush, the acute care hospital. You could base it on locations if you'd like. You can even build in electives. But this level of depth, we've defined 18 to 24 months of the resident's life in about 3 lines of text. That's all we're looking for. So at the end of the day, combined O&P residency, it could look just like it is today, where the residents trained intensively in O&P training week over week, day after day. That's the current standards. But we can be flexible. You could do nothing but O followed by nothing but P, 9 months of O, 9 months of P, and we would still consider that a combined residency. Plus, any of these models that I'm showing you, you could stretch them out to 24 months, no problem. Furthermore, we could do something a little different. What if you wanted to do intensive orthotic training for 6 months, followed by intensive prosthetic training for 6 months, and then just for the fun of it, let's do combined training for the final 6 months. Is that okay? Sure, NCOPE's fine with it. As long as the residents are hitting their MAVs, go for it. There's a lot more flexibility under the new standards. The models in the middle and the bottom, that doesn't fly under the old standards, but it works great with the new standards. Now let's talk about ensuring comprehensive O&P training with minimum activity volumes. Minimum activity volumes, or MAVs, are achieved by a combination of visits where the resident observes, assists, or independently performs patient care. And a minimum number of visits is defined for specific orthoses/prostheses, as well as specified levels of autonomy. The one thing I want to be clear about, though, is an activity is not a patient. An activity is an office visit. So let's look at a new transtibial prescription. Patient with a unilateral transtibial amputation, they come in week 1, they get their initial eval. That's one activity. You give them a shrinker at week 1 and they come back 7 days later. And you cast them for a prosthesis at week 2. Now we're up to 2 activities. Then a week after that, you do a transtibial test socket fitting. That's 3 activities. That's week 3. Then week 4, they get their prosthesis delivered. Their definitive prosthesis is theirs. The resident has effective patient education, and they're up to 4 activities now. Plus, a new patient's going to need to come in for follow-up. So we schedule them for their first follow-up 1 week out after that. And now we're up to 5 activities. So 1 patient, 5 activities, no problem. Transfemoral patients, you're probably even going to get more. We know they might need 2 test sockets, or they might need a little bit more follow-up. So it's very easy to actually recognize that each visit is going to count for an activity. If the resident sees 1 patient an hour, they work 40 hours a week, that's 40 activities. That's a lot. So in terms of minimum activity volumes by visit type and patient demographics, there's a higher focus on evaluations for orthotic cases versus prosthetic. They need to be involved with 50 evals for orthotic cases and just 35 for prosthetic. But the numbers shift a little bit on the prosthetic side with things like diagnostic fittings. So while I like a good old diagnostic orthosis fitting, we don't require them under the standards, but that resident's going to need to do 35 test sockets. Furthermore, follow-up and adjustments. That's much more common in prosthetic care, and the number for follow-ups and adjustments, that goes up for prosthetic caseloads. But another big change is pediatric prosthetic care is no longer a requirement. Under the previous standards, we used to have pediatric prosthetic care listed as a required patient population. And then we started to have a lot of residency sites go, Chris, we don't have access. We can't do it. And they wouldn't even apply to get accredited. And as we started to look into the numbers and where residents were seeing pediatrics, it turns out they're going to places like Texas Scottish Rite Hospital. In terms of orthotic minimum activity volumes, you notice here we define the autonomy, observe, assist versus independently performing. And at the end of the day, the resident must complete 50 total AFO office visits where they're independent for 25 of them. Foot orthoses, they need to be independent for 15, but a total of 25. LSO, TLSO, wrist hand orthoses need to be independent for a minimum of 5 and a total of 10. But KFOs is where it gets interesting. When you look at the data, KFOs account for right around 2% of the average orthotic resident load. They're pretty rare. And recognizing those numbers, we've adjusted it. The resident doesn't need to provide any independent KAFO care. And given how rare they are, it's okay, but they do need to assist in at least 5 visits for a total of 10. Now, could they do some independent KFO care? Sure. It's just not a requirement underneath the new standards. And we also have electives. Lower limb electives, for example, we have diabetic shoes, supramalleolar inserts, KOs, tibial fracture orthoses, shoe mods, and clubfoot orthoses. If you're at the VA, you're probably going to see a fair number of diabetic shoes and inserts and KOs. Children's Hospital, probably not too many of them. And we have both of those clinic types hosting residents, and that's okay. We want to give residents diverse opportunities and diverse clinics the chance to take on residents. So the resident must see at least 3 of those orthoses on the list and provide independent care a minimum of 25 times across at least 3 of those orthoses for a total of 30 visits. We have electives for upper limb and spinal as well. And you'll see scoliosis, that's an elective. It's no longer a required intervention because similar to pediatric prosthetic care, it turns out facilities that specialize in children's O&P services, like a Shriners, generally get most of the work if you're in a market where those clinic types exist. So that is an elective, knowing darn well the VA just doesn't see a lot of scoliosis. They do occasional degenerative case, but not much. But we do have things like cervical orthoses and CTOs and humeral fracture orthoses. You'll see a lot of those at acute care hospitals and facilities that treat adults, but probably not many at the Children's Hospital. The key here is for the electives, the resident must have 15 visits independent across at least 3 of those orthoses for a grand total of 25. And for prosthetic minimum activity volumes, the focus is easy: trans-tib and trans-fem. The resident must have at least 60 transtibial visits where they're independent at least 40 of those 60. For trans-fem, that number is 45 visits where they're acting independently for at least 25. They also have lower limb electives very similar to what we had for lower limb orthotic electives. They must be independent for at least 10 of the following prosthesis types and have a total of 25 activities logged. Post-op care continues, and they must have exposure to at least one of the post-op interventions, RRDs, shrinkers, or IPOPs. They need to independently provide a shrinker or an RRD at least 5 times and be involved in visits at least 10 times, either assisting or observing. Upper limb, there's no independent requirement, and that's okay. A lot of residents generally do assist through most upper limb cases, especially considering how complicated some of them can be. There's an argument that maybe it's not entry level, but residents still need to get 20 visits for upper limb cases, but they don't need to be the independent clinician providing the care for any of those 20 visits. They need to assist in at least 10 of them, however. Another thing that I want to emphasize is fabrication activities. There's truly value in fabrication activities, and there's actually no restriction in the standards on the amount of time residents spend performing technical procedures. But I want to be clear, having a large volume of technical opportunities doesn't change the minimum activity volumes as defined. And those MAVs are tied to office visits where the patient is present. Thermoforming a test socket, that's not an MAV. Fitting the test socket is, however. Now, there's lots of competencies that relate to technical skills. So if you're at a facility where you go, we do a tech rotation, keep it up. It probably offers a lot of value. As a matter of fact, there's 7 competencies below, all focused on psychomotor skills. But I want to be clear, NCOPE Tracker doesn't even track FAB. It never has. And the other thing to keep in mind, and I have some residency sites that actually epitomize this statement. Sites that have minimal fabrication requirements do not yield persons less likely to pass their board exams. When I looked at sites that said, Chris, we don't have a CFAB anywhere within 200 miles, and we outsource everything. Those residents have letters after their name these days, more than likely, and they're CPO. Now, sites that had very low patient encounter volumes before we identified MAVs, we actually found a pretty clear cutoff where folks, if they didn't hit a certain number of experiences, they never got the letters CP, CO, or CPO after their name. Furthermore, there are limits on off-the-shelf orthotic services, and I want to be clear. Off-the-shelf are orthoses that require minimal self-adjustment. I'm talking about knee sleeves with no straps. I'm not talking about L1832, where you have to telescope it, cut it, adjust it, and tweak it. Custom fit orthoses are best provided by the orthotist. There's no limits on that. But your resident shouldn't be fitting truly off-the-shelf items as defined under CMS and by the MAPs more than 20% of their total case encounters. So the orthosis at the bottom, that's custom fit. And the other thing is NCOPE's going to verify sites have adequate exposure. So how are we going to verify sites have adequate exposure? If you're seeking accreditation as a brand new site on or after July 1st, we're going to ask you to give us a report that actually identifies the patient populations and orthoses that are being seen to prove you have access to all those required populations. And for our sites that are seeking renewal after July 1st, we're going to look at your residents' case logs. Minimum activity volumes that we have are based on the 5th percentile of privately owned residency sites. It doesn't include hospitals like UCSF. It doesn't include large multinational companies like Out-of-Pocket Patient Care. The data is based on private sites that are small or medium businesses. And we looked at the 5th percentile, meaning those MAVs, 95% of residency sites hit them. In terms of competencies, we have a new competency framework. And if you look across OT and PT, medicine, nursing, there's some consistent themes: professionalism and ethics, communication, knowledge, decision-making, patient care, interprofessional collaboration and systems-based practice, professional development. On that note, that's the direction that we took the new competency framework as well. When we looked at the feedback from O&P residency directors, we looked at over 1,900 final evals of the resident where it said, write down 3 strengths or 3 weaknesses of that resident. The terms, professionalism and ethics, communication, decision-making, patient care, professional development, those all showed up in the evals that O&P directors were already filling out. These are areas and domains that already matter. So we're not really changing things up. We just recognize that a competency, AFOs aren't a competency, it's a piece of plastic. And across those 7 domains, there's 44 unique competencies, 6 tied to professionalism, 3 tied to communication, 5 tied to knowledge, 8 tied to clinical decision-making, 12 tied to patient care, 3 tied to interprofessional collaboration and system-based practice, and 7 tied to professional development and well-being. And now they focus on transferable skills. Under the old version of the standards, we use terms like beginning, developing, advancing, and competent. And they were very well intentioned. Actually, it's a scale used by the American College of Graduate Medical Education. But the term developing, the resident has limited experience and may continue to have some difficulty with the skill or behavior, frequently requiring coaching, reinforcement, and close supervision. Versus advancing, the resident has additional experience and often performs skills or behaviors effectively in common situations. Occasionally requires continued coaching and reinforcement and supervision. If my resident approached me and said, Chris, you said I'm developing for trans-tibial, but I think I'm advancing. Could you tell me what you saw that you didn't mark me advancing? I'd really struggle to give them a straight answer. That's why the new standards, they're focused on observable behaviors. This is based upon work by Jonathan Day, who's a PhD CPO out of Oklahoma University Health Science Center, and Carol Day, who's a PT PhD faculty member there as well. And we realized we need to actually identify observable behaviors. So now when the resident says, Chris, I was wondering, you marked me as developing with regard to involving the patient and or family and care planning, and I want to know why I'm not advancing. Well, now they actually have the observable behaviors. Well, I saw all of these items that fall under the heading of developing, but I didn't see these ones under advancing. So as a director or mentor evaluating the resident, we'll even tell you what you should be seeing at that point. The competency frameworks, they're listed here. And out of respect for your time, I'm going to let you review those as a PDF. They're also on the website. They're with our standards and the QR code I shared. But I want to just take at least a few moments and talk a little bit about recruitment, posting applications, and hiring your next resident. I want to be clear, residency sites are accredited education training programs. Now you have business licenses and facility accreditation. You're allowed to bill Medicare, and that's awesome. But residents who are enrolled in education programs, NCOPE accredited sites, get protections at students and trainees that do go beyond the protections of local, state, and federal labor laws. The Resi program must advertise the program in a clear, accurate, and transparent manner to enable the prospective applicant to make informed decisions. And they should only advertise positions at sites that are actively accredited. So you can't post something on OP ResCast that says, we're looking for a resident at this office that's not accredited. And also, the advertisement needs to list the city and state of the accredited site. They're curious about the patients they're going to see. They want to know what's a typical day look like for a CPO. And I'd really appreciate if we put the names of mentors and directors there. Also, the program's duration. How long is the program going to take? If you want to run it over 24 months, that's great. You have to say it up front. You also need to identify the number of directors or mentors at the site and the number of satellite and partner clinics that the resident may rotate through. You also need to identify transportation requirements. Does the resident need a car to do a residency, or are they only going to go to one office? Heck, I know residency sites where the resident has a company vehicle. You need to tell them how it's going to work on the front. You don't have to give them a company car. Also, the advertisement must identify the criteria used for picking candidates. You need to actually look at things where you can compare apples and apples. How's their past experience? What was their GPA? Instructor recommendations? But you have to identify, how are we going to pick our residents? It has to be done in a manner that ultimately you do actually can justify who you picked. Furthermore, you need to identify what's your timeline for contacting them. Opening up an application on OP ResCast and then not following up with them for weeks and weeks doesn't work. You need to tell them, we will follow up with all residents on November 30th. That's fine. But tell them how it's going to work. We need transparency more than anything. And we have a whole appendix that just defines exactly how things should work with regard to OP ResCast. What's the minimum duration you can actually advertise it, and even the exceptions. The other thing I want to just be clear about, the standards have integrated guidance. So while the standards are pretty darn long, we have guidance statements, we have excerpts that actually explain in plain language, this is what we really need. This is how we're going to measure it. And this is what we're going to have you submit in order to demonstrate that you've met those standards.